Good morning. Welcome to Clinical Snippets. Today we'll talk about the spinal axillary or the cranial nerve level. For the anatomy part, it originates in the medulla oblongata, then passes through the posterior triangle of the neck, and then supplies the clavicular head and the sternal head of the sternocleidomastoid and the trapezius muscle. We'll be examining the 11th cranial nerve or the spinal axillary nerve. It has two supplies, one to the sternocleidomastoid, second to the trapezius. Firstly, we'll start with the sternocleidomastoid. For the inspection of the sternocleidomastoid, we'll look for the sternal head and the clavicular head of the sternocleidomastoid bilaterally. We'll look for any atrophy, undue prominence or loss of muscle. We'll ask the patient to move towards the right side, and the left side sternocleidomastoid becomes prominent. Then we'll ask the patient to move towards the left side, the right side sternocleidomastoid becomes prominent. Now we'll look for the motor movement of the sternocleidomastoid. In this, we'll apply a firm pressure and the patient is asked to move the head from the midline towards the left side. Here we can see the sternocleidomastoid becomes prominent. Similarly, we'll ask the patient to look to the midline, then we'll apply a pressure and ask the patient to see to the right side, and the left side sternocleidomastoid becomes prominent. Here you can see the prominence of the sternocleidomastoid. Now we'll examine the sternocleidomastoid bilaterally. At the same time, we'll ask the patient to touch his chin to the chest and we'll apply a firm pressure on the forehead. Here you can see the prominence of sternocleidomastoid bilaterally and symmetrically. If there is an injury to the right side of the sternocleidomastoid, then the head will tilt towards the right side. Now we'll be examining the trapezius muscle. First, the inspection. We'll look for the trapezius contour, the shoulder blades. Then we'll look for the scapula. The winging of scapula is present or not. Then we'll check for the motor functions of the trapezius. We'll ask the patient to give a firm pressure, apply a firm pressure against the wall. We'll ask the patient to apply a firm pressure against the wall. If the scapula moves laterally, then we'll say, and the prominence is there like a bird's wing, and the scapula moves laterally, then we'll say the spinal axillary nerve is affected and the trapezius muscle is damaged. Now we'll be examining the power of the trapezius muscle bilaterally. We'll ask the patient to shrug his shoulder and apply a firm pressure against the shrugging the patient is doing. If the patient is able to counter the pressure we are applying, then the trapezius muscle is normal and the spinal axillary nerve is not involved. We'll ask the patient to apply a firm pressure. As you can see, he is able to counter the pressure we are applying and there is no motor involvement and the trapezius muscle is normal. If there is unilateral loss of power in the trapezius muscle, it can occur after a neck surgery or if lymph node biopsy is taken and the spinal axillary nerve is damaged, or after carotid endarterectomy. It can also be damaged bilaterally in a neuromuscular junction involvement, as in myasthenia gravis, Lambert-Eaton syndrome, or motor neuron disease. Scapulohumeral dystrophy. In this, the patient will have a chin to chest abnormality, and the paraspinal cervical and the paraspinal muscles are involved. Then it can also involve the element, or the muscles can be involved. In element lesion, there will be fasciculations, atrophy, loss of power. If there is myopathy, then it will be painless, symmetrical and bilaterally. Thank you.
Hello everyone, today we are going to study the 12th cranial nerve. The 12th cranial nerve is the hypoglossal nerve. It's a purely motor nerve and functions as a somatic motor nerve to supply the muscles, the intrinsic and the extrinsic muscles of the tongue. It innervates all of them except the palatoglossus, which is supplied by the 10th cranial nerve. It is a very important nerve because it aids in movements of speech, articulation and swallowing. The hypoglossal nerve also has some postganglionic sympathetic fibers which innervate some of the vessels and small glands of the nerve. The hypoglossal nerve has got 4 branches: the meningeal branch, the thyrohyoid branch, the descending branch and the muscular branch. But only the muscular branch is the true branch because it originates from the hypoglossal nuclei. It actually originates from the hypoglossal nuclei. Now let us look at the course of the hypoglossal nerve. Its anatomical location is at the lower part of the medulla oblongata. It begins as these 2 nerves which originate from the hypoglossal nuclei. They travel laterally and ventrally. Then as they are exiting towards the base of the skull, they split into 2 and they reach the hypoglossal canal. Then they reform, travel down through the neck to the angle of mandible, then to the base of the tongue, and finally they innervate all the muscles of the intrinsic muscles and extrinsic muscles of the tongue. These are the muscles of the tongue. The genioglossus, which is responsible for drawing the tongue forward or protrusion. Hyoglossus is responsible for retraction of the tongue and depression of its side. Styoglossus is responsible for drawing the tongue upward. And the intrinsic muscles, which are 4 in number, modify the shape of the tongue. They can shorten the tongue or narrow the tongue and also cause the curving of the tongue. They are superior longitudinal, inferior longitudinal, transversus and verticalis. Now let us study some disorders of the hypoglossal nerve. First, let us study the nerve lesions. Now in a supranuclear lesion, the lesion is above the level of the hypoglossal nerve. So there is contralateral weakness of the nerve, and in an intranuclear lesion there is an ipsilateral weakness of the nerve. So the tongue will deviate away from the lesion, whereas in an intranuclear nerve palsy, 12th nerve palsy, the tongue will deviate towards the lesion. Now what this means is that if there is a supranuclear lesion of the right cranial nerve, then on protrusion the tongue will move to the left side, which is the contralateral side. In a similar manner, if there is an infranuclear lesion of the right hypoglossal nerve, then on protrusion the tongue will deviate to the same side, that is the right side. In infranuclear lesion, we predominantly get atrophy, severe dysarthria and swallowing difficulty, and these features do not happen as markedly in supranuclear lesion. Supranuclear lesions can occur predominantly because of strokes and progressive bulbar palsy, whereas the common causes of infranuclear palsy are brainstem lesions, motor neuron disease and trauma. Now there are certain neurological disorders like amyotrophic lateral sclerosis and progressive bulbar palsy where the lower motor neuron features are seen, such as atrophy, glossoplegia, which is the complete inability of the tongue to move, and dysarthria and dysphagia. Now there is a very rare neurological disorder called the neck-tongue syndrome, in which there is sudden severe pain in one side of the upper neck and the back of the head, and simultaneous numbing or tingling on the same side of the tongue. And it is triggered by sudden neck movements, especially rotation. And what happens is the C2 nerve root, it gets irritated or pinched during this head movement because it travels very closely with the hypoglossal nerve. Now in obstructive sleep apnea, there is already a decrease in the muscle tone of the body, and the hypoglossal nerve which supplies the genioglossus also gets affected. So the function of genioglossus is to protrude the tongue out. But in obstructive sleep apnea, because of reduced muscle tone, the genioglossus retracts and obstructs the trachea, and it impedes the airflow. So we treat the condition by giving hypoglossal nerve stimulation if continuous positive airway pressure is not helping. Thank you.
Now let's go towards the examination of 12th cranial nerve. In the examination of 12th cranial nerve, we will look for strength, bulk, dexterity and fasciculations of the tongue muscles. What are fasciculations? Fasciculations are the abnormal visible involuntary twitching of the muscles of the tongue. In the examination part, we will first do inspection. In the inspection portion of the examination, we will look for the deviation of the tongue and we will look for the fasciculations of the tongue. Now, for the deviation of the tongue, we will ask the patient to protrude his tongue outside, and we'll look for the deviation towards either of the side of the tongue. थोड़ा सा जीभ बाहर निकालिए, अब इस तरफ करिए, इस तरफ करिए, ठीक. So you can see there is no deviation of the tongue to either of the side, and he can actively deviate his tongue according to his will. So there is no palsy or unilateral weakness of the 12th cranial nerve. If let's say for example there is unilateral weakness of the left side, there will be deviation towards the same side of the tongue. This is due to the normal unopposed action of the genioglossus muscles. Now we will check for Dinkler's sign. What is Dinkler's sign? If during protrusion the tongue is deviated to the left side, जीभ बाहर निकालिए, in this subject there is a normal tongue because there is no unilateral weakness, but if the unilateral weakness is present, there will be bunching of the tongue towards the same side and the opposite side will be normal. This is known as Dinkler's sign. Now let's go towards the fasciculations portion. How do you check for that? We'll ask the patient to open his mouth while the tongue is resting inside the mouth. मुंह खोलिए. As you can see, there is no abnormal movements or fasciculations of the tongue. If the abnormal movements or fasciculations are present in the tongue, that is suggestive of lower motor neuron palsy of the 12th cranial nerve. Now let's move towards the palpation portion of the examination. In palpation portion of the examination, we will look for the consistency and power of the tongue. While seeing consistency of the tongue, we will ask the patient to protrude his tongue outside and we will check for consistency of the tongue. थोड़ा सा जीभ बाहर निकालिए. As you can see, the tongue is normal in consistency. If the tongue is small or stiff, that will be suggestive of upper motor neuron palsy of the 12th cranial nerve. If the tongue is flabby, it will be suggestive of lower motor neuron palsy of the 12th cranial nerve. Now we'll look for the power. To look for the power, we'll ask the patient to exert the pressure against the cheek and we'll push from the outside against in the opposite direction to check for the power. अभी जीभ को अंदर ही इस साइड रखिए और थोड़ा सा ताकत लगाइए. ठीक है, अब इस साइड ऐसा करिए. Okay, the power is normal in this patient.